Okay, so let's start with the strabismus. Strabismus can be a little bit, maybe a little bit challenging to study, a little bit difficult, needs a lot of understanding. You need to understand the basic concepts of it. So if you are listening to or reading strabismus for the first time, I assure you that it will not be a pleasant experience. You will face a lot of difficulties to grasp all information, but the good news is that you are not alone. All of us had been through the same experience. So basically, if you are not a strabismologist, if you are not practicing strabismus, it will be difficult to imagine everything present in the books. And the more you read, the more you listen to strabismus lectures or to theoretical strabismus, the more you will understand. So don't worry if you just don't have the full picture now, but it will come with reading and with more listening. The more you listen, like this picture, I consider it like optics. You see, remember optics in the first part? When you read it for the first time, you almost understood like 10 or 20%, but the more you read, the more you understand. So don't worry, it will be come with time and come also with understanding of the basic concepts. So this introduction is important for you, so you know what we are going through. Okay, so this lecture will be divided as different sections. As we know, it will start with the clinical anatomy, like just a reminder of what have been told in the anatomy about the extraocular muscles. And then we will go through some fundamental concepts about the strabismus to understand why does the strabismus occur. So, you know, what will be the basic principles of it. And then we will come through rapidly through the assessment of the visual acuity and the assessment of strabismus from the perspective of a written exam. So it is not like an oral exam or a practical exam where you are going to do this stuff for yourself, but you need just to know what are the principles. So this can be sometimes asked in the MCQ exams. For more information about that, this will be in the third part. Regarding the comitant strabismus and incomitant strabismus, and we will know what are the differences between them. Then the nystagmus, and we will conclude by the management of strabismus. Okay. So let's get started with the clinical anatomy. What are the extraocular muscles and what are their action and their nerve supply? So as you all know, we have 4 recti: superior rectus, the inferior rectus, the lateral rectus, and the medial rectus. And we also have 2 obliques, the superior oblique and the inferior oblique. Okay, so these are the 6 extraocular muscles that are responsible for the extraocular muscle movement. What about the nerve supply for these muscles? The nerve supply of most of the muscles come from the oculomotor nerve. So the oculomotor nerve has a superior division and inferior division. The superior division will supply the levator palpebris superiosus, which is responsible for elevation of the eyelid, and the superior rectus muscle. The inferior division will supply the medial rectus, the inferior oblique, and the inferior rectus. The trochlear nerve will supply the superior oblique. So if there is trochlear nerve palsy, this will result in superior oblique palsy. If there is abducent nerve palsy, it will cause lateral rectus palsy because the lateral rectus is supplied by the abducent nerve. So this is just to know what are this when we come to the paralytic strabismus, you just need to know which nerve is responsible for which muscle. The next thing is the action, and this will can sometimes be a little bit confusing. So this action is dependent on the insertion of the muscle over the globe. So we have the 2 easy muscles, the lateral rectus and the medial rectus. They have only one primary action. So the lateral rectus will be responsible for abduction of the eye, while the medial rectus will be responsible for the adduction of the eye. No more actions. So here we come to the sometimes a little bit confusing muscles. the superior and inferior rectus and the superior and inferior oblique. So let's start by the superior and inferior rectus. So the recti has the same action like their names. So the superior will cause elevation, the inferior will cause depression, while the obliques have the reverse of their names, like the superior oblique will cause depression, while the inferior oblique will cause elevation. Okay, so this is the regarding the elevation and depression. The superior muscles are intortors, like the superior rectus and superior obliques are causing intorsion, while the inferior muscles are extortors, like the inferior oblique and the inferior rectus causing extorsions. The third action is the abduction and adduction. So the obliques are abductors. So the superior oblique and inferior obliques are abductors, while the recti are adductors. So the superior rectus and inferior rectus are adductors. To summarize the action, the superior rectus is elevator, intortor, and adductor. The superior oblique is intortor, depressor, and abductor. The inferior rectus is depressor, extortor, and adductor. And finally, the inferior oblique is extortor, elevator, and abductor. So this is important to know. If each muscle is paralyzed, what will be the resultant effect on the strabismus, or which kind of strabismus will develop? So I hope that this is clear so far. Please don't confuse this. Don't confuse the action of the extraocular muscles with how to test the extraocular muscles, or how to test the action of the extraocular muscles. So let's start first by the easy muscles. The medial recti are adductors, while the lateral recti are abductors. So the medial recti will cause adduction, and you test them in adduction. So if the eye is unable to adduct, this could be a problem in the medial rectus. On the other hand, if the eye is unable to abduct, this could be a problem in lateral rectus, like what happens in the sixth nerve palsy. But what about the recti, the superior rectus, the inferior rectus, the superior oblique, and the inferior oblique? Please concentrate with me. We have two elevators of the eye, the superior rectus and the inferior oblique. And we have two depressors of the eye, the inferior rectus and superior oblique. Both the superior rectus, let me just bring my pen. The superior rectus and the inferior obliques are both elevators, and inferior rectus and superior obliques are depressors. But everyone has a tendency to elevate or depress the eye in a certain direction. So the recti tend to elevate the eye in the lateral direction, or in the abduction. So the superior rectus elevate, or the best action, or it should be tested when the eye is elevated and abducted, while the inferior rectus should be tested while the eye is depressed and abducted. The inferior oblique is tested when the eye is elevated and adducted. The superior oblique is tested when the eye is depressed and adducted. And why is this? So to just understand that, as I said to you, the superior rectus and the inferior obliques are elevators. So if both muscles contract to the same degree, both of them will elevate the eye in the primary position, like that, in the middle. So if the eye is looking straight upward, so this will be due to the combined action of the superior rectus and the inferior oblique. Both of them elevate the eye in the straight position. And also, if the eye is looking down in the straight position, this will be due to the combined action of the inferior rectus and superior oblique. If the eye is looking to the up and lateral position or in the abduction, in this case, the superior rectus becomes the only elevator of the eye. Likewise, if the eye is looked down and right, in this case, the inferior rectus will be the only depressor of the eye. On the other hand, when the eye is looked up and in, or an elevation in adduction, then the inferior oblique will be the only elevator of the eye. And also, if the eye is looking down and in, like if the patient is looking to his nose, then this will be the action of the superior oblique only. As this, in this case, the superior oblique will be the only depressor of the eye. This is related to how is the muscle is inserted to the eye. So this will result in that each muscle is tested in a specific direction. And by testing this specific direction, and we see if the eye cannot move in this direction, we understand that there is a problem in a specific muscle, so we can localize where is the problem or which muscle is affected. Okay, I hope that this is clear. Based on that, or based on the affection of the extraocular muscles or affection of the nerves and the others, this will result in the clinical presentation of the strabismus, like what will be the normal position and what will be the abnormal positions. The normal position, it is called the orthophoria. So in this case, both eyes are aligned. By the way, we don't judge strabismus by just one eye. We have to always to consider both eyes. So if both eyes are well aligned in central position, in this case, it's called orthophoria. If the eye, if during fixation, or if the patient is fixing on a central target and there is one eye which is turned inside, this is called esotropia. If the patient is fixing on a central target and one eye is deviated outward, then this is called exotropia. If a patient is fixing on a target and the eye is looking downward and the patient cannot elevate, then it is called the hypotropia. And finally, if the patient cannot elevate his eyes or cannot, sorry, the eye is turned upward, then this is called hypertropia. So ESO, EXO, hypo, hyper refers to the direction. Tropia refers to a manifest squint. A manifest squint which can appear by the cover test. On the other hand, there is the latent squint. Latent squint is called phoria. So phoria, it can be esophoria, exophoria, hypophoria, hyperphoria. This is refers to a latent squint which will appear by uncover or alternate cover tests. Okay, so this is like a very quick overview of the clinical anatomy of the strabismus and how does it, why the muscles are affected, or what are the kinds of nerve supplies the muscles, and what is the direction of action, and how these muscles affection will present by different clinical presentation. So let's now move to some fundamental concepts. So you may think, what is the strabismus and why does it occur? Basically, we have what's called the normal binocular vision. We have the virtue of ability to fuse the images between both eyes in order to be perceived as single image. This is called a single binocular or normal single binocular vision. And how does it come? It is single and binocular because we see by both eyes, yet we perceive it as one in the cerebral cortex. In order to have this normal binocular vision, one should have normal fusion and integration of both images from both eyes. And this comes by two mechanisms that I'm going to tell you right now. So basically, there should be bifoveal fusions with high degree of stereopsis. This will be like around 40 seconds of arc. So in order to see our normal binocular vision, we need to fixate on the same target by both foveas and this with resultant stereopsis, which means that we can appreciate the depth perception. And this is measured by seconds and minutes of arc, and the less, the better. So normally it should be 40 seconds of arc or less. The normal binocular vision develops after birth from early infancy and completed with fusion and stereopsis by the age of 8 to 10. And this is called the amblyogenic period. What is meant by the amblyogenic period? This is a period where there will be development of the motor and sensory system. Like there will be development of the association between the extraocular muscles and the visual potentials of the patient, of the eyes, the visual pathway, and the cerebral cortex. So all of these systems, the motor and sensory systems, are integrated together in order to produce a single binocular vision with stereopsis. And this takes time, takes like up to 8 to 10 years. So what happens if there is, so this is like the maturation is associated with maturation of the visual functions in both sensory and the motor. So in this time interval between up to 8 or 10 years, if there is any interruption of this sensory development or motor development, this will result in the absence or defective normal binocular vision. So both of them should develop hand in hand till 8 to 10 years in order to give the patient the advantage of stereopsis and normal binocular vision. What happens if it is interrupted? This can result in amblyopia, which is the defective vision. So I have like some questions. Phoria and tropia, again, the difference. So Dr. Muhammad, the tropia is a manifest squint. Like the patient, when you see the patient without any tests, without any cover or alternate cover test, you see a true deviation. So you see a manifest deviation. But the phoria, you will not be able to detect it unless you are doing the uncovered test or alternate cover test. So the patients in normal position, they look normal, or the both eyes looks aligned. But when the patient is not concentrating, or he has a fever, or there will be any condition that will disturb the higher centers in the brain, which are controlling the binocular vision or controlling the both eyes, this will result in that one eye will drift, one eye will be deviated, and it will return back again to the normal position when the patient is still regaining his concentration or regaining his control over both eyes. You are welcome. Next question. What is the meaning of the second of arc? Okay, so this is an arc. Let me bring my pen. Like this is a second of arc is a unit of measurement. So if we just consider that we have an arc like that, we have like two arcs, both of them will make like around 60 minutes, assuming that this is like clock hours, and each minute will be consisting of 60 seconds. A part of this arc will be called like 10 seconds or 20 seconds or 30 seconds or 40 seconds or 40 minutes or 50 minutes. So this is just a unit of measurement. Okay, so this will be the unit of measurement of the stereopsis. It will be measured by seconds of arc. It's like the same concepts applies to measurement of the minutes of arc when we are measuring the visual acuity or the visual angle. Remember, in the visual acuity and the physiology, we will say that the patient has a stereo acuity of 5 seconds of arc or 5 minutes of arc. So this will be the same concepts applies. Dr. AA, this means that at the age of 8 years, no single vision? No, we didn't say that. We are just saying that it is developing. It will be developing until it will be fully maturated at the age of 8 to 10 years. That's why it is, if it is interrupted and we do like amblyopia therapy for at that time, it can improve, but it will be fully maturated after 8 or 10 years. So after that age, if there is persistent obstruction of the visual axis till 8 or 10 years, and this will result in loss of the binocular single vision. But after that time, if you do amblyopia treatment, it will be unlikely that it will restore the vision. Again, it is not like a certain age, Dr. Kenan say it means no stereopsis. No, again, it is not like black and white. It will develop, but to a certain degree, but not fully, depending on many factors, depending on how much the visual axis or how much time did the visual axis suffer from any deviation or any obstruction to the visual stimuli, and also the density of this obstruction, and if there is any treatment provided like amblyopia therapy or not. So it will be like a continuous process. So it will start after birth or by development of the normal vision, and it continues till we reach the age of 8 and 10 to be fully maturated. Dr. Pragnia, so the smaller the number of seconds of arc, the better the 3D vision. Yes, exactly. This is what I meant. Okay, so I think that I respond to all your questions. Let's continue. So based on our understanding to the binocular single vision, we can now understand what is the strabismus. In simple words, strabismus is the misalignment of the eye. Like we have both eyes should be aligned together with their visual axes are aligned together, but for some reasons they are not aligned anymore. So when the patient is looking to the right or looking to the left or up and down, both eyes they should move together so that both eyes should place the object on the fovea of both eyes. If this doesn't happen, then there is a strabismus. And the strabismus, or this misalignment, can be present in only single gaze or in all gazes. Like, so in particular gaze, it is more common with what's called the concomitant strabismus. And in all directions of gazes, this will be a specific feature for what's called the concomitant strabismus. We will come to this in the next slides. Okay, and as a result, the strabismus can be, the strabismus will occur as a result of impairment of the binocular vision, or the impairment of the binocular vision can lead to strabismus. Like, let's see an example. If this patient has this whitish pupil meaning that this patient has congenital cataract mostly, and this congenital cataract will lead to stoppage of the stimuli, of visual stimuli to the left eye. So the brain didn't receive impulses from the left eye, resulting in the patient will only fixate by the right eye, and the brain is starting to ignore the left eye. So what will be the result of impairment of the binocular vision? The brain no longer perceive image from both right and left eye. This will result in strabismus. So the motor supply to the eye will be impaired because of the impairment of the sensory system. So this close relationship between the sensory and the motor system is what will result in strabismus. There will be loss of the sensory, leading to defective motor innervation to the left eye. And this will also result in amblyopia, like there will be no impulses perceived to the brain by this left eye. And also the reverse may occur, like the motor may affect the sensory. Like for a patient, like for this child has a 6 nerve palsy. For the sixth nerve palsy, there will be esotropia, and there will be limitation of abduction. The lateral rectus is paralyzed. So what happens? What happens in this time that the patient is fixating by the right fovea all the time, and in the left eye, the image will fall on an extrafoveal location. So as a result, in this early development period, this patient will do, or as a compensatory mechanism, will do what's called suppression. The patient will suppress the image coming to the left eye to avoid diplopia and avoid confusion. And this will result in, if it is persistent, it will result as a sensory mechanism to develop what's called eccentric fixation. Like the patient will develop like a new location of the fovea, of extrafoveal location. So this is called eccentric fixation. So you can see that the motor problem, which is the sixth nerve palsy, resulting in sensory problems and also defective binocular vision. So this close relationship between the sensory and the motor development means that the strabismus may arise from a disturbance in either the sensory or the motor development, especially when the patient is young, because there is what's called the visual plasticity. The patient has the early years of the patient, the patient has very flexible visual system that they can adapt to changes very rapidly. So if they have loss of visual sensation, they can develop suppression or can develop eccentric fixation in order to overcome the diplopia. And this doesn't happen in the adults. So the younger the patients, the visual functions are more vulnerable, and they will respond aggressively to the cessation of the visual stimuli, either by sensory mechanisms or motor mechanisms. Okay. Okay, so I hope that this is clear till now. And now we are going to discuss a word that we just mentioned, which is the incomitant and comitant strabismus. We have two words. You need to differentiate between both of them that will classify, or there will be the two major groups of strabismus cases or strabismus patients. There are some strabismus patients who have comitant, or sometimes referred to as concomitant squint, and others who have the incomitant or strabismus or incomitant squint. So what is the difference between them? Simply, the difference is in the angle of misalignment of strabismus. The angle of misalignment of strabismus, or the angle of deviation of the visual axis of the squinting eye. So if the angle of deviation of the squinting eye is always the same, regardless of the direction of movement of the eye, and in this case, it's called the concomitant strabismus. Again, concomitant strabismus, like if there is an angle between the deviation of the eye and the visual axis, this angle will be the same whether the patient looks right, to the left, or looks up, looks down. It will be the same angle. Then it will be called the concomitant strabismus. And this type is most commonly present in childhood, like comitant esotropia, like comitant exotropia. So because this is the period of visual maturation, so those patients tend to develop strabismus that will affect all directions of gazes, and it will be the same angle regardless of the patient's the eye's position. And in this case, for those patients, a squint surgery or a muscle surgery will result in alignment of the eyes in all directions, because the angle or the angle of misalignment or the angle of deviation is fixed in all directions. So if we do a surgery, it will fix the angle in all directions. Okay, it is very important to understand this concept. On the other hand, the incomitant strabismus is present when the angle of misalignment is measured at the particular test distance is variable. Like the patient has an angle which is increasing on right gaze, or increasing on left gaze, or up gaze or down gaze. So what will be the factor that will control this angle? What will be when will be the problem become more evident or more clear? This depends on the direction of gaze will be greatest in the direction of action of the impaired muscle. So if there is impairment of the muscle, this will result in concomitant squint. So in order to just make it more understandable, so basically the concomitant strabismus, this will result, this is abnormality in a single nerve or a single or multiple muscles. So it is just the affection. You remember when we talked about the supranuclear control of the extraocular muscle movement, we said that there will be higher centers, then there will be brainstem nuclei, then there will be nerves, and there will be muscles. So if there is affection of the nerves or affection of a disease that will cause local affection of the muscles, this will result in concomitant strabismus. So that the affection or the angle of deviation will be the maximum, the most in the direction of action of the impaired muscle. For example, if a patient has sixth nerve palsy, right sixth nerve palsy, and I'm asking him to look to the right, so I am asking him to do abduction of the right eye. Well, there will be a problem. The patient is unable to abduct the right eye, so the angle of deviation will be the maximum. So that if we ask the patient to check for the or to move his eyes in the action of affected muscle, then this will result in increasing the concomitance, increasing the angle of deviation. And this kind of strabismus, the concomitant strabismus, it is more common to occur in the adulthood rather than childhood. Okay, let me give you some examples. So this patient has concomitant esotropia. In the primary position, the patient has esotropia. While the patient is looking up, the angle, it is almost the same. When the patient is looking down, the angle is almost the same, looking up to the right, down and right, right, left, up and right, down and right. The angle is almost the same in all directions of gaze. This is called the concomitant esotropia. But what happens in the concomitant esotropia? Look here, this patient again has right esotropia. The right eye is a little bit deviated inward. Look, when the patient is looking to the right, the angle almost disappeared. Both eyes can look to the right normally. But what happens when the patient is looking to the left? So what can we see? The right eye is looking to the left normally, but the left eye is unable to abduct. So the angle here is increasing. There will be change in the angle because the left eye cannot move to the left. The left eye has a paralytic strabismus. The paralytic strabismus because of the sixth nerve palsy. The same thing appears when the patient is looking up and down. So you see that the angle is variable when comparing to when the patient is looking to up and right and down and right. So when the patient looks up and right, down and right, it looks almost normal because this is away from the direction of action of affected muscle. But when the patient is looking to the left or up and left or down and left, there will be limitation. Just hold on, please. Okay, you got it now? So it will be, the limitation is the maximum at the direction of action of the affected muscles, and this will result what's called concomitant squint. And in this case, for patients who have concomitant squint, the purpose of the surgery not to improve the direction of action of muscles in all cases, because no single muscle surgery will improve the direction of action in all cases, because you see, it is the affection is not symmetrical in all cases. So we cannot do surgery that will improve the direction in all cases. But what we do here is just to do muscle surgeries that will control the eye in the primary position and in the down position or the reading position. So if and it has a certain indications, like if the patient doesn't have diplopia in the primary position or down gaze, if they don't have any abnormal head posture, or if they don't have any what's called torticollis or affection of the muscles. So this will result in, we don't do surgeries for those patients. So we will come to the surgeries later on, but this is just for the record now to understand what is the difference in the management and our goal for management in incompetent and competent. Dr. Pragnia, can you please describe terms for looking up and right, down and right, like dextroversion, levo, elevation? Okay. So this will be the primary position. This is the primary position. This is elevation. This is depression. This is, if we are talking about the right eye, this is abduction, and this is the abduction. And this is dextro elevation, dextro depression. So dextro elevation is looking up and right by both eyes. Dextro depression is looking down and right by both eyes. Levo elevation, looking up and left by both eyes. Levo depression is looking down and left by both eyes. Okay, clear? Would you like me to repeat it again? You're welcome. Okay, let's now, so I hope that it is clear so far. And let's now move to another important topic, which is the assessment of the visual acuity and assessment of strabismus. It is sometimes asked in the exams, in the MCQ exams. However, it is not in no much details. It will be just by like theoretical knowledge. So it doesn't ask you to a practical level, but we'll just know what are the terms and what are the specific things about the assessment of visual acuity, some headlines about assessment of visual acuity and assessment of strabismus. So for the visual acuity in children, it can be assessed by different methods depending on the age of a child. So we can classify children into 3 categories. The first one are the pre-verbal, who are less than 1 year old. The other group will be the preschool, which are between 1 to 3 years old. And finally, the older children, which are more than 3 or 4 years old. So what are the different methods? Sometimes they bring you in the MCQ different methods, and they tell you all these methods are essential or can be used for measurement of the visual acuity to a specific child of a specific age group, except. So you need to know what are the different types depending on the age. So what are these types and how do they work? First of all, in the first 3 months, the patient or the child can fix and follow. So when you bring him a target of interest and you are moving it between the or moving it in front of his eyes, the patient or the child can move his eyes toward the target. This is called fix and follow, or he has what's called CSM, or central steady maintenance of fixation. Fix and follow, or CSM, central steady maintenance of fixation. The next thing, or the next test, is the resistance to occlusion. The child who has impairment of visual acuity of one eye will be resisting to occlusion of the sound eye. So this girl has normal vision of the left eye, and she has defective vision of the right eye. Once the examiner occluded the right eye, the patient was happy. But if the patient is occluding the left eye, just even without touching her, the patient or the girl is crying. This means that her normal eye is the left eye. And this indicates impairment of vision of the right eye. Another test, depending also on the patient preference, the child preference, is the preferential looking. So there are some tests using, yes, Dr. AA, sound eye means a healthy eye. So the patient always resists the occlusion to the healthy eye. For the preferential looking, we have Taylor cards and the Cardiff cards. The Taylor cards and the Cardiff cards are cards that will show some drawing or lines with thicker or thin lines, and we always try to check if the patient is trying to look to the pattern. This test or the preferential looking test is depending on a principle, which is that the child tended to or prefer to look to a pattern rather than a homogeneous stimulus. So if he can see the pattern, he will move his eyes toward it. So if there is, here are these cards showing this card of cards, showing some drawing like a fish or a ship. And if the child can see them, he will look at them. If he cannot see them, then you can bring them other cards with larger line or larger images in order to check if he can see it or not. The same applies for the Taylor cards, presenting some cards with alternating dark and white bands, and check if the child can move his eyes toward these. If he moves his eyes toward them, then he is interested in them, then he can see them. Another test based on the same principle is the optokinetic drum. Optokinetic drum, when it is rotated in front of a patient or any normal individual, it will initiate what is called the optokinetic nystagmus. Optokinetic nystagmus, it will have two phases, fast phase or slow phase with the direction of movement of the drum, and a rapid corrective phase against the direction of the drum. So when you are moving this drum from up and up and to down, this will result in nystagmus, which has slow phase downward and rapid phase upward. So this will mean that this child can see these alternating dark and white bands. So what we do next is we just make these bands more thin. We make them thinner. So if we make them thinner and we rotate the drum and the child can still show the optokinetic nystagmus, then this means again that the child can see them. The same thing here. You can see this alternate. This is also a test of a preferential pattern or preferential looking. So you see that the child is looking to this alternating dark and white bands and ignoring this empty circle. If the eyes, if the child's eyes are wandering here and there and everywhere, then this means that the child cannot see. So all these tests are, and finally, like around between 9 months to 1 year, we can do what's called the 100 and thousands test. Like we bring the child a lot of small, tiny gums or tiny stuff, so we can test the child ability to see them, to recognize them, and to pick them. But this is if the child can proceed his hands in order to pick them, then this means he can see them. But this test shouldn't be done at younger age than 9 months because this child is not yet developed the manual dexterity. So we just want to make sure that the patient has this manual dexterity in order to pick the objects, so he can see them and pick them up. After that, after 1 year, from between 1 to 3 years, we have different cards based on matching, like what's called the K-test. K-test, it's a matching test. Like we are showing the patient like a flower and give him like this card and ask him to point to the image that's present on his card that is similar to that it is presented in front of him. There are two tests of this category. We have the K-test and the Allen test. Also the Sheridan-Gardner test, it will be also based on the same principle. So for patients or for children between 1 to 3 years, we depend on matching tests. After that, after older children, we depend on the HOTV test, like we're presenting again. It is also like a matching, but we will start using letters. So we use the letter H, letter O, letter T, letter V, and we are the patient is, or the child is, pointing to the similar letters from his card. And finally, if the child is 6 years or older, we can use the Snellen chart. Okay, got it now? So you know now what are the different kinds of tests that we can be used for visual acuity measurement in children. I hope that this is clear. Regarding the motor examination of the eye, we have also different tests. So first of all, the Hirschberg test, which basically we are checking the central pupillary light reflex, whether it is central or not. This is a crude test, and it is not used for measurement of any visual or not used for taking a decision of a surgical procedure, but it is just a crude test. Like for this child, he has a pseudo esotropia because of the broad nasal bridge and the presence of epicanthal folds. So this child has apparent esotropia, but it is not a true esotropia because you can see that the pupillary light reflex is central. Other group of tests, they are called the cover uncover and alternate cover and prism cover test. So basically we are doing these tests to dissociate the extraocular muscle or dissociate both eyes, and to detect if the presence of any true squint or manifest squint. This can be done by the cover test, or the presence of latent squint by the uncover alternate cover test, and measure the angle by prism cover test. And also we can do what's called Kremski test, in which we are placing the prism in front of the deviating eye until we see the light reflex is central. And there is also modified Kremski test, where we place the prism in front of the sound eye or normal eye until the pupillary light reflex looks normal in both eyes. So we will not go through this because actually this is a full lecture to just discuss all this, and it will just will not be of great value for the MCQ test. For Park 3-step test, we will discuss it in more details or in full details in the fourth nerve palsy, because it is important to understand the Park 3-step test to understand how the fourth nerve is affected, or how the fourth nerve palsy will affect the Park 3-step test, and also because the interpretation of Park 3-step test is asked in the exams. The Maddox rod, it is a kind of high plus cylinders placed in front of eyes and can be used in order to detect what is called the heterophoria, and heterophoria for far. So we have for heterophoria, like if the patient has esophoria, hypophoria, hyperphoria, hypophoria, this can be detected by the Maddox rod, which is based on the principle of dissociation of the binocular vision. So the right eye will see an image that is different from the left eye. We have two types, this like the single Maddox rod, which can be used for heterophoria, and so the other eye doesn't have any lens in front of it. And we have this test where we are using two Maddox rod, which is called the double Maddox rod test, using red in front of the red eye, green in front of the left eye, and this can be used to measure the cyclotorsion. How much encyclotorsion or excyclotorsion does the patient have? And this can be also discussed again in the fourth nerve palsy. Finally, we have the nystagmus examination and motility examination. Again, this is out of the scope of this course. So just know, so for this, for you, just know that this also is a part of the full motor examination of a patient. But here is an important thing, which is what will be the effect of a prism over the eye. Like, so the eye, look at this figure or this figure A, you can see that a prism is this is the normal alignment. Like if the patient is looking to a target X, So he is fixing on this target X by the fovea F. But what happens if a patient, if we place a prism in front of this patient's eye? So this prism, what will it cause? As we know from the optics that rays will pass always or deviate always toward the base of the prism. So rays from the X will pass toward the prism and it will deviate to the base of the prism. So it will be assuming that this is the nasal and this is the temporal. This is the nasal, this is the temporal, this is the nasal, and this is the temporal. So assuming that the image of the object is falling on the nasal to the fovea, what will happen? Well, the patient now cannot see the image coming or cannot see the object right now because actually the eye can only see in straight lines. So he will see the image of the object in straight lines because it will be shifted toward the apex. So the image will be shifted toward the apex while the object or light rays are shifted toward the base. So the patient actually will see the image or the prism will cause displacement of the image toward the apex of the prism. That's why the eyes move to the apex. You can see the eye moves temporal in order to be able to look to this target, the target X. This is the concept is very important. So if we have a patient who has esotropia or exotropia, we can place prisms in front of their eyes in order to measure this angle of deviation. And this can be done by putting a prism with base against deviation. So always remember that if we have a squint and we measure, we can see the as we mentioned that we can measure the squint by by prism cover or by prism. We always put the prism for measurement of the angle of a squint with the apex with the deviation and the base against deviation. Okay. So assuming that this patient has esotropia, like you can see left esotropia, so we need to measure the angle of a squint of the left eye. We put the prism base out or base against deviation. We always name the prism with after the base, not the apex, and the apex is with the deviation. So the base out and the apex in because there is esotropia. So this will be the normal alignment of the eye, of the right eye. The left eye, the patient has esotropia, so the object falls on an extrafoveal location. And when we are putting the prism in front of the left eye with the base against the deviation or apex with the deviation, this will result in that the light rays will be moving toward the base, so that the image will be moving toward the apex and the eye will move toward the apex. So here is the eye is already moved toward the apex because the eye is already esotropic. So by placing a prism in front of the left eye, the image or the object will fall on the fovea. So by this, the patient will be able to fix on this object and we can be able to detect the accurate measurement of the angle of a squint. So this is just a brief about the motor examination. Regarding the sensory examination, we mentioned that both motor and sensory systems can be affected and both of them can result in strabismus. So we mentioned the tests used for measurement of strabismus, and sometimes in the exam they can tell you all of these tests are used for motor examination except, or all these tests can be used for sensory examination except. So this will be important to not to confuse between the many tests. For the sensory examination, we need to know if both eyes can fuse the image in the same time, or what's called there is simultaneous macular perception and simultaneous fusion, because this what will lead to the stereopsis. So we have different tests for that. First one, it's called the Bagolini striated lenses, where the patient is wearing polarizing glasses, and then placing a dot in front by flashlight, resulting in, like, if there is a polarization like that and there is polarization of this like that, so the right eye will produce one line, so this is the right, and the other left eye will produce a left line. So if the patient can see them crossing, then this means that the patient has normal, he is normal, or has what's called abnormal retinal correspondence if there is a manifest deviation. If they are away from each other, this means that there is diplopia. If there is only one line, so this means that the other eye has suppression. Or if there is a breaking in the line from the center, so this will mean that there is a suppression scotoma. The other test, which will also measure the sensory system, is the Worth-Ford dot test. So basically, the patient is not wearing polarized glasses, but he is wearing a red-green glasses. The red eye or the red glasses will be in front of the red eye. The left glasses or the green glasses will be in front of the left eye. And we present a box which you show one red dot, two green dots, and one white dot. So normally the patient, if he has normal fusion and normal stereopsis, normal binocular vision, he should see one red dot, two green dots, and the whitish one will be a fusion between the red and the green. So it will be an intermediate color between the red and the green. So in this case, this means that this patient is normal. If the patient see only two reds, so this means that there is suppression of the left eye. So he cannot see the green. So he can see now the red dot is red by the right eye, and the white circle is red also by the right eye. Likewise, when the patient has right suppression, he will see three green dots because he can see the two green by the left eye, and the white circle can be seen green by the left eye. If a patient has like paralytic squint, like there is a sixth nerve palsy, so the both eyes are not well aligned together. So if every eye will see a different image. So the right eye will see two red, and the left eye will see the three green. This means that the patient has diplopia. Okay, so this is a test for sensory fusion. It is called the Worth-Ford dot test, or a test for the single binocular vision. Other tests for stereopsis, which is the highest grade of binocular single vision, are Titmus test, which is using polarized glasses, and ask the patient to hold the wing of the fly by these polarized glasses. We have also the TNO test, which is used by red-green glasses, Frisbee test, and finally what's called the Lang test. So Titmus, TNO, Frisbee, Lang test, these are tests for the stereopsis. So please don't confuse the names. Sometimes they are asked in the exams to check which test is used for what. Finally, the final test is an important test for the especially for patients who are malingers or who are faking that they have loss of vision. It's called the binocular fusion test without manifest squint. How do we know if a patient doesn't have manifest squint, and we need to know if so they don't have abnormality in the motor system? There is no manifest squint, but they could have abnormality in the sensory system. They could have or don't have binocular fusion. So how can we test that? This is done by what's called the 4-diopter base out prism. So how does this test, or how is this test performed? So we can see that both eyes are well aligned. We place the 4-prism diopter in front of one eye, and we observe for the corrective movement of the other eye. So here we are placing the prism in front of the right eye. This prism is base out, so the eye will move toward the apex as we agreed. So the right eye will move, and owing to or due to the hearing law of equal innervation, the same innervation that reaches the right eye will reach to the left eye. So since that the right eye is moving to the left, the left eye will also move to the left by the equal innervation to lateral and medial rectus of the left eye. So far, so good. So what happens next? So in this case, we deviated the image in front of the right eye by this prism. So the right eye is now fixing on the image. However, the left eye is not fixing. The left eye is like moving outside its well. The left eye is moving without its purpose or without its need. The left eye was fixing already, didn't have any problem. So what happens next? That there will be corrective movement of the left eye. The left eye will regain central fixation. This means that this patient has bilateral binocular fusion. He can fuse by both foveas of both eyes because of because of this corrective movement of the eyes without the prism. So again, we deviate the image by placing the prism base out, 4 diopter base out in front of one eye, and then the right eye will deviate toward the apex in order to regain fixation, and left eye will move by hearing low. And then if patient has bilateral or binocular fusion, he will regain fixation by the left eye. It will restore the fixation. The left eye will become central again. So if a patient is claiming that he cannot see, we can do this test by just placing the prism. He will not be able to control it voluntarily. So if he can see, there must be a corrective movement. But what happens if a patient has like suppression of the fovea, or he cannot see with the fovea? So we place the prism in front of one eye or the right eye. And check for the corrective movement, like that. So right eye deviate, the left eye deviate by the hearing low. And then what happens? There is restoration of the corrective movement. So this will be the previous slide was corrected, was repeated. So let's see that this patient is not seeing or doesn't have binocular fusion. So we place the prism in front of the right eye moves, the left eye moves with the hearing low. So this means that there is no abnormality in the fovea of the right eye, there is no suppression. But in the left eye, well, what happened? Nothing happened. The left eye didn't fix. The left eye didn't become central again. So this means that the fovea of the left eye is not working. There is foveal suppression of the left eye. So this test can be used, one of the sensory tests or one of the tests used to detect if there is abnormality in the fusion between both eyes. Okay, is it clear? So the result is that there is no restoration movement.